Namaskar, myself Dr. VIPUL Gurjar. I am the head and the professor of surgery in SBKS Vadodara and private practicing surgeon in Vadodara. Today, I love to talk on full thickness rectal prolapse treatment. Before that, I am disclosing that my lectures or my discussion is about to sensitize about the available procedures, which is practically important. I'm not going that much detail about the evidence or anything theoretical part. So this is the lecture in a practical approach. Okay. Now the full thickness rectal prolapse. This is something different from the ODS. This full thickness rectal prolapse patients are mostly not associated with the obstructive defecation syndrome or may be partly affected with the obstructive defecation syndrome. Okay. Now there are the two type of approach for the treatment, surgical treatment. One is the perineal and second is the abdominal approach. Now, I want to much more emphasize about the two procedure, that is a POP and SIRS, and third one is a transrectal sacrorectopexy by the Chiute procedure. This is the main two procedure I want to discuss. That will be on the last part. Okay. Now with the perineal approach, the most available perineal approach is a Altimer and Delorme procedure, which is normally not preferring the treatment. If patient is not fit for the general anesthesia, as well as there is a irreducible rectal prolapse, you can go with the Delorme or the Altimer procedure. The why? Because of the bleeding and surgically somewhat a difficult treatment, the peoples are not preferring the perineal approach. Among the perineal approach, one important non-evidence based surgery is given by the late Dr. Chiute sir. Dr. Chiute sir has proposed transrectal sacrorectopexy. It is considered in a perineal approach, but it has doesn't have any evidence on literature. It is not published, but myself as well as many surgeons are doing a surgery very well. We'll discuss later on. Okay. Now about the abdominal approach. In abdominal approach, mainly there are the two type of laparoscopy or the open surgery. Mostly this rectal prolapse surgery was in the past done by the posterior mesh rectopexy. Within this surgery, by laparoscopy or open, we are doing a dissection in the posterior wall of the rectum and up to the sphincter level. It is like a CME dissection of the rectal cancer. Then after, we took a 3 by 6 centimeter mesh, 3 by 6 inch mesh, and we fixed presacral S2, S3 and S4 level, and we wrap rectum not fully in a 3/4 manner, and we keep anterior part open, and we fix the lateral end of mesh with the rectum. But in my practice, I have shown that the satisfaction of patient is not a good. A larger amount of dissection is required, as well as the obstructive defecation syndrome is increased in a posterior rectopexy. Then after, another technique is a simple suture rectopexy, in which the sacral part of the rectum is dissect out, as well as there is a dissection near the lateral border of the rectum up to the sphincter. After this good dissection, the posterior wall of the rectum is fixed with the suture with the presacral fascia, and the evidence as well as the experience by many surgeons, they are very much satisfied with this procedure. So the posterior rectopexy with the mesh and simple rectopexy, the results are more practically satisfactory in a simple suture rectopexy. Since a few years ago, the one surgery is come in a picture is ventral mass rectopexy. This ventral mass rectopexy is come because we are worried about the erectile dysfunction in a male as well as in a female patient, lateral nerve injury, which is possible in the posterior mass rectopexy, as well as the posterior wall of rectum is important for the sliding during the defecation process. So if we are fixing that posterior wall, the chances of obstructive defecation is increased. That's why the people has started the ventral mass rectopexy. In this, there is a dissection at the sacral promontory and S2 level, and there is a one more dissection in the lower rectal part up to the sphincter. Then after L-shaped mesh, inverted L-shaped mesh is fixed with the most lower part of the rectum, and the vertical angle of mesh is fixed with the sacral promontory. Then after peritonization of the mesh is done, so there won't be a exposure of mesh. There are a lot of paper and are available on this ventral mass rectopexy, and this ventral mass rectopexy are mainly popular by the Mumbai based Zen hospital, and they are getting a very good result. Uh, the what are the disadvantage of ventral mass rectopexy? In this, there is the chances of mesh related complication. It is possible. But what are the advantages of ventral mass rectopexy? Ventral mass rectopexy has a good advantage of prevention of posterior wall fixation, as well as there is a less dissection in compared to posterior wall mass rectopexy. Now I want to discuss something about the newer technology for the full thickness rectal prolapse. That is, one is the POPS, pelvic organ prolapse suspension, and SIRS, SIRS, so intraperitoneal rectal prolapse suspension. These two techniques, this is actually the one technique, but name is different by because of the different approach. It is given by the Dr. Longo sir. He is an Italian surgeon and he is innovator of the MIPH as well as the STAR procedure. Okay. And now what is the SIRS or what is the POPS surgery? The SIRS surgery, in which we do, there is no dissection at all. It is done by the laparoscopy surgery, in which we are taking a rectangular shape 1 inch 30 by 30 centimeter length proline mesh. It is a 1 inch broad, the rectangular angular shape 30 by 30 limb. Okay. In a laparoscopy, we did a reverse threadline position, a head down position. We push a rectum from outside, then angle of mesh is fixed at the most lower part of anterior wall of the rectum and with the suture, as well as we are fixing a lateral 2 suture with the rectal wall. Then with the anterior superior iliac spine from the outside 2 inch above and medially, we put the incision, dissect out the external oblique aponeurosis muscle. We expose that external oblique muscles, and we'll go the retroperitoneal. So sorry, pre-peritoneal level, and we put laparoscopy, Maryland or any blind instrument in a through the external opening in the pre-peritoneal space. We can observe its tip which is entering inside the pre-peritoneal, and we have to guide up to the rectal wall. Then we have to put an artificial opening to bring that tip of instrument. It is done simultaneously over the both side, left and the right. Then after we catch the both end of mesh, and then we pull outside. So the rectal itself pull come out ups, and that's why it prevents the external prolapse. In this way, we are supporting the rectal wall as well as whole pelvic floor. That means that this full thickness rectal prolapse are associated with the tri-compartment prolapse. They are the maybe not associated with the isolated rectal wall. But in this technique, whole pelvic floor is come up, and the simultaneous symptoms of urinary, rectal or the uterine prolapse, it is treated. After pulling off this sling, we are fixing the external part of mesh with the external oblique aponeurosis, and then we close the external oblique aponeurosis and suture the wound. If patient having a more prolapse about the uterine as well as some vesical part, then the suturing of this angle of mesh is anterior to the uterus, and that will consider as a POP, pelvic organ prolapse suspension. Mainly it is done in a female patient where the gynecological as well as urological symptoms are more prone and evidence than the rectal, then the anterior part of uterus is taken in the sling. What are the advantage? This advantage that it prevents the obliteration of the Douglas pouch, which is possible in a ventral mesh rectopathy. This POP and the SIRS are important to improve the rectal prolapse as well as the pelvic floor prolapse. And in this way, many times gynecological problem of hysterectomy is can be saved. Now another perennial approach for the full thickness rectopexy is by the Chiute SIR. This POPs and SIRS, before that, POPs and SIRS also it's not evident because it is not published in the journals or in a theoretical part. So you can do, but with some consent. Chieftain's rectal prolapse surgery, in which we are giving a lithotomy position, a 30-degree low down head. Then we push a rectum inside with the specially available length Chiute proctoscope. This special Chiute proctoscope is a 20 centimeter long proctoscope. In this condition, first we have to be sure there should not be a small bowel in a pouch or rectal pouch. So the lithotomy position is very important. Then we push this long proctoscope till that the tip of proctoscope touches to the sacral promontory. So that's why it straightened the posterior wall. Then after you identify blindly S2, S3 and S4 level, and you take a suture, deep suture only in a midline. See, only in midline. There won't be any major structure in a midline. If you are taking a lateral, there may be a chances of neurovascular injury. So with the presacral fixation transrectally, through and through, transrectally at the S2, S3, S4 level with the interrupted suture with the PDAs 10. And then after you can take a single row of Chiute procedure of piles with the Vicryl 20 that fix the lower rectal mucosa also. Then after we inject the sclerogen in a presacral fascia with the spinal needle. It is only at the 6 o'clock position. Never ever inject elsewhere. Otherwise, neurovascular or some vital injury may be possible. I have done a lot this transrectal sacrorectopexy in older age group as well as in a young patient or even in a child also. The result is are the very satisfactory, as well as the recurrence rate is very minimum, and whenever the patient is unfit for major surgery, anesthesia with the counseling, this Chiute procedure is excellent procedure for rectal full thickness rectal prolapse. So this is something basic idea of a full thickness rectal prolapse surgery. Thank you very much. Bye.